will speak about chromosomal pathology, and second part of our lecture about singleton diseases. Okay, and we will speak about general characteristics of chromosomal diseases, about numerical and structural chromosomal abnormalities, about clinical genetic characteristics of different chromosomal syndromes, about general characteristics and classification of singleton disorders, and clinical genetic characteristics of some monogenic disorders. Okay, let's start from incidence of chromosomal abnormalities. Chromosome diseases are present in at least 10% of spermatozoa and in 25% of mature oocytes. Between 50% and 20% of all recognized pregnancies and in spontaneous miscarriage and many more zygotes and embryons are so abnormal and severe beyond the first few days or week after fertilization is not possible. Approximately 50% of all spontaneous miscarriages have a chromosomal abnormalities, and the incidence of chromosomal diseases in morphologically normal embryos is around 20%. This observation indicates that chromosomal diseases account for a loss of a very high proportion of a human conception. On this slide, you can see the incidence of chromosomal abnormalities in spontaneous abortions. Percentage figures relate to total of chromosomal abnormal abortuses, and you can see that most frequent will be monosomies on X chromosomes, also trisomy on 16 chromosome, triploidy, and other chromosomal trisomies. From conception onwards, the incidence of chromosomal abnormalities falls rapidly. By birth, it has declined to a level of 0.51%, although the total is much higher, around 5%. If only stillborn infants are considered. As for newborns, most frequent in newborns, we can see trisomy on 21st chromosome. Also, balanced translocations, also different abnormalities of sex chromosome we can see in newborns, like trisomy on X chromosomes and Klinefelter syndrome, which characterized by presence of one Y chromosome and two X chromosomes, and trisomy on X chromosome characterized by presence of two Y chromosomes in male. It is notable that among the commonly recognized aneuploidy syndromes, there is also a high proportion of spontaneous pregnancy loss. And you can see that trisomy 13 associated with 95% cases of spontaneous pregnancy loss, trisomy 18 with 95, trisomy 21 with 80, and monosomy X with 98. Doctors, we know that maternal age associated with high risk of chromosomal diseases. And on this slide, you can see the results of investigation, which show us that maternal age after 36 years old associated with increased risk of Down syndrome, as an example of chromosomal pathology, and with other chromosomal diseases also. And this data was has been got during the invasive prenatal diagnostics, such as chorionic-Villus sampling, which we can use between 11 and 12 weeks of pregnancy, and amniocentesis at 16 weeks of pregnancy. Next question will be general characteristics of chromosomal pathology. So general characteristics of chromosomal diseases. First one, chromosomal diseases arise in gametes or at the first divisions of zygote. Second one, all states of pathogenesis fall at the prenatal period. Multiple congenital malformations is the main clinical feature of chromosomal pathology. Next one, the etiological and pathogenetic therapy is not developed for chromosomal diseases. We can use only symptomatic approach or symptomatic treatment for chromosomal diseases. And the last one, it's possible to apply prenatal diagnostic method for prenatal diagnostic of chromosomal diseases. As for classification of chromosomal abnormalities or chromosomal mutation, we know the following types of chromosomal abnormalities. First one is numerical abnormalities. So it's a type of chromosomal abnormalities associated with abnormal number of chromosomes in human karyotype. And numerical abnormalities may be divided to aneuploidy and polyploidy. Polyploidy may be divided on triploidy, tetraploidy, and aneuploidy may be divided on monosomy, trisomy, and tetrasomy. Structural abnormalities of chromosomes include translocations such as reciprocal and Robertsonian, deletions, insertions, inversions. Inversions may be paracentric and pericentric, and rings isochromosomes. Also, we know about chromosomal diseases associated with presence of two different cell lines in same patient. We call it mixoploidy. So it's maybe divided on mosaicism and chimerism. Mosaic forms of chromosomal diseases are rare, less than 1% among all cases of chromosomal diseases. And in this patient, in this group of patients, we can find cells with normal karyotype, with presence of 46 chromosomes, and cells with the abnormal karyotype like trisomy or monosomy. Numerical abnormalities of chromosomes involve in the loss or gain of one or more chromosomes, which is referred to as aneuploidy, or the addition of one or more complete haploid complements, which is known as polyploidy. Loss of a single chromosome results in monosomy. Gain of one or two homologous chromosomes is referred to as trisomy and tetrasomy, respectively. Trisomy is the presence of an extra chromosome is referred to as trisomy. Most cases of Down syndrome are due to the presence of an additional number, 21st chromosome, so-called trisomy 21. Other autosomal trisomies, which are compatible with the severe autoterm, Patau syndrome, it's trisomy 13, and Edwards syndrome, trisomy 18. Most other autosomal trisomies result in early pregnancy loss, with trisomy 16 being a particularly common finding in first trimester spontaneous miscarriages. The presence of an additional sex chromosome, X or Y, has only mild phenotypic effects. Basic mechanisms of numerical abnormalities of chromosomes are associated with different mistakes in meiosis 1 and meiosis 2. Segregation at meiosis of a single pair of chromosomes in normal meiosis, which you can see on the left part of this picture, non-disjunction in meiosis 1. In meiosis 1, you can see in a second picture, and non-disjunction in meiosis 2. You can see on the right part of this picture. So, and it's lead with different variants of the presence of chromosomes in zygote, and here you can see an example associated with mistakes in meiosis 1 and 2 and leading to different abnormalities of sex chromosomes. So, trisomy is one of the most frequent chromosomal abnormalities, and trisomy 21, for an example, is usually caused by failure of separation of one of the pairs of homologous chromosomes during anaphase of maternal meiosis 1. This failure of the bivalent to separate is called non-disjunction. Less often, trisomy can be caused by non-disjunction occurring during meiosis 2, when a pair of sister chromatids fail to separate. Either way, the gamete receives two homologous chromosomes, such as disomy, and if subsequent fertilization occurs, a trisomic conceptus result. The consequences of non-disjunction in meiosis 1 and meiosis 2 differ in the chromosomes found in the gamete. An error in meiosis 1 leads to the gamete containing both homologous of same chromosome pair. In contrast, non-disjunction in meiosis 2 result in the gamete receiving two copies of one of the homologous of the chromosome pair. The origin of non-disjunction may be paternal or maternal, but studies using DNA markers have shown that most children with autosomal trisomy have inherited their additional chromosome as a result of non-disjunction occurring during one of the maternal meiotic divisions. And Here we can see the origin of meiotic errors leading to aneuploidias, and we can see that most number of cases of trisomy 13, 18, 21 trisomy on X chromosomes depend on mistakes in maternal meiosis. And Klinefelter syndrome and monosomy X are associated with paternal reasons. Non-disjunction can also occur during and early mitotic divisions in the developing zygote, and this results in the presence of two or more different cell lines, a phenomenon known as mosaicism. The absence of a single chromosome is referred to a monosomy. Monosomy for an autosome is almost always incompatible with survival two-term. Lack of contribution of an X or a Y chromosome results in a karyotype 45X0, which causes the condition known as Turner's syndrome. As with trisomy, monosomy can result from non-disjunction in meiosis. If one gamete receives two copies of a homologous chromosome, so-called disomy, the other corresponding daughter gamete will have no copy of the same chromosome. It's called nullisomy. Monosomy can also be caused by loss of a chromosome as it moves to the pool of the cell during anaphase, an event known as anaphase lag. Polyploid cells contain multiples of the haploid number of chromosomes, such as 69 triploidy or 92 tetraploidy. In humans, triploidy is found relatively often in maternal growth from spontaneous miscarriages, but survival beyond mid-pregnancy is rare. Only a few triploid live births have been described, and all have died soon after birth. Triploidy can be caused by failure of a maturation meiotic division in an ovum or sperm, leading, for example, to retention of a polar body or to the formation of diploid sperm. Alternatively, it can be caused by fertilization of an ovum by two sperm. This is known as dispermy. A triploid usually results in early spontaneous miscarriage. Structural chromosomal abnormalities result from chromosome breakage with subsequent reunion in a different configuration. They can be balanced or unbalanced. In balanced translocation, the chromosome complement is complete with no loss or gain of genetic material. Consequently, balanced translocations are generally harmless, with the exception of rare cases in which one of the breakpoints damages an important functional gene. However, carriers of balanced translocations are often at risk of producing children with an unbalanced chromosomal complement. When a chromosome rearrangement is balanced, the chromosomal complement contains an incorrect amount of chromosome material, and the clinical effects are usually very serious. A translocation refers to a transfer of genetic material from one chromosome to another. Every reciprocal translocation is formed when a break occurs in each of two chromosomes, with the segments being exchanged to form two new derived chromosomes. A Robertsonian translocation is a particular type of reciprocal translocation in which the break points are located at or close to the centromeres of two acrocentric chromosomes. A Robertsonian translocation results from breakage of two acrocentric chromosomes. We know 5 pairs of acrocentric chromosomes, like 13, 14, 15, 21, and 22, at or lost their centromeres with subsequent fusion of their long arms. This is also referred to as centric fusion. So when two acrocentric chromosomes lose their short arms and combine in one large metacentric or submetacentric chromosome, it's called Robertsonian translocation. We know that ribosome genes responsible for the synthesis of ribosomes are located in short arms of these acrocentric chromosomes. And losing of these short arms can't lead to very serious consequences, because presence of ribosome genes in other acrocentric chromosomes are enough for normal functioning of ribosomes. That's why carrier of Robertsonian translocation will never have any clinical peculiarities of this translocation. But this patient will have a very high risk of chromosomal pathology in their offspring. Second type of translocation is reciprocal translocation. Reciprocal translocation, pay attention, involves the breakage of at least two chromosomes, which with exchange of the fragments and without centromeres. So with exchange of the fragments without presence of centromeres. So on the slide, also on this picture, you can see Robertsonian and reciprocal translocation. Deletion. A deletion involves loss of part of chromosome and results in monosomy for the segment of the chromosome. Usually, a very large deletion will be incompatible with several to term, and as a general rule, any deletion resulting in loss of more than 2% of the total haploid genome will have a lethal outcome. An insertion or duplication occurs when a segment of the chromosome becomes inserted into another chromosome. If the inserted material has moved from elsewhere in another chromosome and the karyotype is then the karyotype is balanced. Otherwise, an insertion causes an unbalanced chromosome complement. An inversion is a two-break rearrangement involving a single chromosome in which a segment is reversed in position. You call this segment inverted segment. If the inversion segment involved the centromere, it is termed a pericentric inversion. If it involves only one arm of the chromosome, it is known as paracentric inversion. On this slide, you can see a pericentric and a paracentric conversion. Syndromes, doctors, associated with chromosomal diseases. Down syndrome is the condition derives its name from Langton Down, who first described it in the clinical lecture reports of the London Hospital in 1866. The chromosomal basis of Down syndrome was not established until 1959 by Lejeune and his colleagues in Paris. Most cases of Down syndrome, around 90% of cases, are due to non-disjunction of chromosome 21, arising during the first meiotic cell division in oogenesis. A small number of cases arise in meiosis II during oogenesis, during spermatogenesis, or during mitotic cell divisions in the early zygote. We know three basic cytogenetic forms of Down syndrome. It's a simple trisomy, translocation form, and mosaicism. Pay attention that only translocation form is inherited, but simple trisomy and mosaicism is not inherited. And on this slide, you can see an example of karyotypes of patients with different cytogenetic forms of Down syndrome, like trisomy 47XX or XY and 21 plus, each with additional chromosome. An example of translocation form. Here you can see translocations between 21st and 15th chromosomes and 21st and 25th chromosomes, and mosaic form. Karyotype of patient with mosaic form will have two types of cells presented through the slash, like first one will be mosaic karyotype, and second one will be normal karyotype. Risk of inheriting of the translocation you can see on this slide. If translocation occurs in mother, its risk will be around 15%. In father, around 5-7%. And when you can see translocation in both parents, risk will be 100%. Incidence of Down syndrome. The overall incidence when adjusted for the impact of prenatal screening, it's approximately 1 in 650 or 1 in 700. Although occurring to any age, the risk of having a child with trisomy 21 increases with a maternal age. This age-related risk has been recognized for a long time, but the underlying mechanism is not understood. The risk of recurrence of any chromosomal abnormality in a live birth in infant after the birth of a child with trisomy 21 is increased by about 1% above the population age-related risk. This increase in risk is more significant for younger women. And in women over the age of 35, the increase in risk related to the population related risk is less apparent. On this slide, you can see incidence of Down syndrome in relation to maternal age. We know that maternal age may influence the risk of chromosomal disease, including the Down syndrome. Here you can see that in maternal age 2025, risk will be 1 in 1,500, 1,350, and 1 in 900 in age 30. But for after the 35 years old, risk will be increasing extremely. And we can see that in maternal age of 45 years old, risk of Down syndrome will be 1 in 30. What are the main clinical features of Down syndrome? In newborn period, we can see hypotonia, sleepy excess nuchal skin, different craniofacial abnormalities such as brachycephaly, epicantic folds, protruding tongue, small ears, upward sloping palpebral fissures, single palmar crease, small middle phalanx of fifth finger, wide gap between first and second toes, atrial and ventricular septal defects, common atrioventricular canal, parent ductus arteriosus. Other abnormalities such as anal atresia, duodenal atresia, Hirschsprung disease, short status, strabismus. Affected children show a broad range of intellectual ability with IQ scores ranging from 25 to 75. The average IQ of young adult with Down syndrome is around 40 to 45. Social skills are relatively well advanced, and most children with Down syndrome are happy and very affectionate. Adult height is usually around 150 centimeters in the absence of a severe cardiac anomaly, which leads to death in 50-20% of cases. Average life expectancy in 50-60 years. Most affected adults develop Alzheimer's disease in late life. So karyotypes may be different. You can see it's maybe simple translocation or mosaic form. On this slide, you can see an example of epicanthus, flat bridge, flat face, upward sloping palpebral fissures, flat bridge also, protruding tongue, epicanthus, excess nuchal skin, dysplastic ears, brachydactyly, the single palmar crease also you can see. On this slide, you can see hands of adult with Down syndrome. Note the single palmar crease in the left hand plus bilateral short curved fifth fingers. It's called clinodactyly. Narrow palate, abnormal shape of teeth, geographic tongue, mental retardation. Patau syndrome, the next syndrome we'll speak about. This is a very severe condition, Bode first described in 1960. They both show incidence figures of approximately 1 in 5,000 and convey a very poor prognosis, with most affected infants dying during the first few weeks of life. In the unusual event of long-term survival, there is severe mental retardation. Cardiac abnormalities occur in at least 90% of all cases. What are the main characteristics? The incidence of trisomy 13 is about 1 in 15,000 live births. The majority of trisomy 13 conception spontaneously abort in early pregnancy. About 75 of cases are due to non-disjunction. The remainder are translocation cases, usually involving 13, 14 Robertsonian translocations. Of these, half arise de novo and half are inherited from a carrier parent. The frequency of 13, 14 translocations in the general population is around 1 in 1,000, and the risk of a trisomy conception for a carrier parent appears to be around 1%. Most live-born affected infants succumb within hours or weeks of delivery. 80% die with 1 month, 3% survive to 6 months. The main features of trisomy 13 include structural abnormalities of the brain, particularly microcephaly and holoprosencephaly. It's developmental defects of the forebrain, different facial and eye abnormalities, cleft lip and palate, post-taxal polydactyly, congenital heart defects, renal abnormalities, and scalp defects. Survivors have very severe mental and physical disability, usually with associated epilepsy, blindness, and deafness. So on this page, on this slide, you can see multiple congenital malformations and in patient with Down syndrome. On the left picture, trigonocephaly, for an example. And incidence of this syndrome will be around 1 in 5,000, 7,000. Craniofacial abnormalities we can see in around 95 or 97% cases. Mental retardation 100. On this page, you can see a child with trisomy 13 showing severe bilateral cleft lip and palate. Edwards syndrome, it's trisomy 18. Trisomy 18 has an overall incidence of around 1 in 6,000 live births. Most cases are due to non-disjunction of the incidence increasing with maternal age. And the majority of trisomy 18 conceptions are lost spontaneously, with only about 2.5% surviving to term. Many cases are now detectable by prenatal ultrasound scanning because of a combination of intrauterine growth retardation, oligohydramniones or polyhydramniones, and major malformations that indicate the need for amniocentesis. About the 1/3 of cases detected during the second trimester might survive to term. Edwards syndrome, the main features of Edwards syndrome include growth deficiency, characteristic facial appearance, clenched bent hands with overlapping digits, rot bottom feet, cardiac defects, renal abnormalities, exomphalos, myelomeningocele, esophageal atresia, and radial defects. 90% of affected infants die before the age of 6 months, but 5% survive beyond the first year of life, and survivors have severe mental and physical disability. Patient with Edwards syndrome have multiple congenital abnormalities in 100% of cases. The prominent occiput and tight clenched hands. Next one question will be sex chromosomal abnormalities. It's the most frequent chromosomal diseases, and main features of this type of abnormalities are clinical manifestation are at puberty period. Mental retardation is not common. Severe malformations are not characteristics. It is possible to treat the patient with hormones. So, lymphatic edema of foot we can see in 65% of cases. This patient will have short height, barrel chest, and widely spaced nipples. Klinefelter syndrome is the most frequent chromosomal pathology. We can see this patient in 500-700 cases. Most frequent karyotype will be 47XXY. Only females are affected. They will have a high height, gynecomastia, infertility, and female stature. On this slide, you can see long arms and fingers in patient with Klinefelter syndrome. This patient, as a rule, will have normal intelligence, but they will have microorchidism, small soft testes. And last one for first part of lecture, it's indications for chromosomal analysis or cytogenetic analysis of chromosomes, because this is the main method for detection of chromosomal abnormalities. First one, it will be multiple congenital malformations, unexplained mental retardation, sexual ambiguity of or abnormality in sexual development, infertility, recurrent miscarriage, unexplained stillbirth, and malignancy and chromosomal breakage syndromes. Group leaders, please send me by mails absent students like in previous lecture. Can you hear me? Doctor, still 5:00 p.m. Send me, please, by mail. Number of your group and only absent students, okay? And we'll go on in 10 minutes. Now we will have a break.